Hello everyone, my name is Khuthala Mnika. I'll be presenting part of my PhD project, which is Pharmacogenomics of Sickle Cell Disease Therapeutic in Africa. However, in this presentation, I'll be talking to you about the analysis of 299 pharmacogenes in sickle cell disease patient in Africa. Sickle cell disease is a monogenic disorder. It is an increasing global health problem. It is also estimated that about 300,000 babies are born with sickle cell disease per year globally. Out of these 300,000 babies that are born, 70% of these babies are born in sub-Saharan Africa. Sickle cell disease is a multi-system disorder that is caused by a single gene mutation in a beta-globin gene where nucleotide A is replaced by nucleotide T. This results from glutamic acid replaced by valine. Hemoglobin cells that have glutamic acid, they are oxygenated and they move freely. However, hemoglobin cells that have valine, they are deoxygenated, they tend to climb to each other and form a long chain in a process called polymerization. This long polymer affects the structure of the red blood cell from smooth round into a sickle shape. This sickle shape, they tend to attach to the wall of the blood vein and block the blood flow. This process is called vaso-occlusion. This vaso-occlusion can lead to other clinical phenotype as indicated in this figure. Management of sickle cell disease aims to reduce the incidence of acute pain episode, acute chest syndrome, and hospitalization. To achieve reducing these incidents, patients are given antibiotics, analgesic to relieve pain, blood transfusion, and hydroxyurea. Hydroxyurea is the mostly widely used medication in sickle cell patients. However, there's a limited study that have been focusing on pharmacogenomics of hydroxyurea. Pharmacogenomics is the study of use, effects, mode of action of drugs, and it is also the study of structure and function of genes. It has been reported previously that hydroxyurea results in potential adverse effects such as infertility, susceptibility to infection. These have been reported to be associated with hydroxyurea. There's a limited understanding, or there's a limited data on pharmacogenomics of hydroxyurea, meaning we need to understand the hydroxyurea molecular mechanism. This we can achieve by exploring the alternative and potential less toxic and more acceptable agent that could equally increase the level of fetal hemoglobin. The rationale of our study is that most of sickle cell patients are on chronic medication and they are subjected to lifelong administration of medication. The second thing is that hydroxyurea is mostly widely used by sickle cell patients, and there's few data on pharmacogenomics of hydroxyurea. Even though hydroxyurea have been reported to increase the lifespan of sickle cell patient, there's still a gap, or there's still a need to investigate the pharmacogenomics in order for us to understand the genetic variation that are associated with drug response. This will help us to improve the quality of life of sickle cell disease patient in Africa. Previously, it has been reported that patients respond differently due to the key genomic variation, mainly BCA11, HBCAR, MIP, as indicated in this table. However, the complete picture of pharmacogenomic determinants of hydroxyurea remain difficult to find, and it has been also reported that genetic differences are also suggested to be the reason for inter-individual variability in pain, as well as a response to anti-inflammatory and opioid drugs. Currently, in our study, we have reported on hydroxyurea-induced microRNA expression in sickle cell disease patients in Africa. So the microRNA that we have reported in this study, we're targeting the gene that have been already reported to be associated with the level of fetal hemoglobin and the hydroxyurea expression. The aim of our study is to investigate the genetic variation in absorption, distribution, metabolism, and excretion genes. These are called ADME genes. So we're looking at the 32 core and 279 extended gene in selected population from Cameroon. To achieve our aim, we have two objectives. The first one is to assess the mean allele frequency difference in sickle cell patient versus ethical match control. The second one was to assess the mean allele frequency difference in sickle cell patient versus the 1000 genome project population. To achieve our aim, we had set up a methodology. So from the 148 sickle cell patient, we had 123 patients that were Cameroonian and 25 patients that were Congolese and 40 sickle cell patients. We employed Pharmacogene platform as a genotyping platform. In this Pharmacogene, we had like 4,627 markers in 1,191 genes. Quality control of the chip was assessed using Affymetrix power tool. After this, PCA was analyzed using a smart PCA. Mean allele frequency difference between cases and control were analyzed. Cases in the 1000 genome population were analyzed. Our first results, let's look at the comparison between our cases and our control. When we compare our cases and control, we have observed that Cameroon population, they cluster together regardless of the sickle cell disease status is presented. This data indicate that the two groups are homogeneous population except for the 4 control individuals which are far away from the cluster. These 4 individuals were excluded, we considered as an outliers and excluded from the analysis. When we were comparing our sickle cell patient from Cameroon and the 1000 genome database, the results show that a sickle cell participant cluster with other African population with a distinct difference from other non-African population, which is American, European, and Asian population. To confirm what we have observed in our PCA, we did a heat map to confirm the results that we've got from PCA, as it has been shown in this figure. Figure B, it shows that our sickle cell patient, they cluster together with African population and they are different with non-African. We then subcategorize Cameroon sickle cell patient according to a variable range of clinical severity. Long survivor, so we had 3 groups, which is long survivor. The long survivor are patients which are age over 40 years, and then the stroke group are patients who had at least 1 episode of overt stroke, and then we had a random group which is patients that are younger than 40 with no stroke. So when we're comparing this group, we saw that allele frequency reveals difference between this subgroup, and we further on compare the one that was significantly different. So our Cameroonian population, the stroke group, and the DRC, when we compare them, looking at the figure B, the figure B shows that the DRC was significantly different with the patient from Cameroon from the stroke subgroup. In this study, we reveal significant difference between African and non-African population allele frequency of core and extended pharmacogenes in commercial available area. In addition, the data has described differences in pharmacogene variants among 2 different groups of sickle cell patients according to their geographical origin. This data emphasize the urgent need to perform a comprehensive investigation of population-specific pharmacogene variants among African population in order to inform clinical management in a satisfactory manner. Lastly, the present data indicate that the appropriate of using commercial available pharmacogene array in African population need a supporting evidence, as we have reported that there were differences in the core pharmacogene between DRC and Cameroonian population. This indicates that there is an intra-African differences in mean allele frequency in these core gene. To conclude, This will be important to consider in future studies of drug response in sickle cell disease patients in Africa. I would like to thank my supervisor, Professor Ambrose Wongam, for supporting me in this journey, and also I would like to thank my group, which is SADC under GenMap umbrella, for the support. Thank you.